Hello and welcome to my talk on CT scanning of the brain. My name is Dr. Sanjeev Bagga, and I'm going to be talking about CT scan imaging of the brain. My references are the Pocket Atlas of Sectional Imaging, Direct Diagnosis in Radiology, Brain Imaging, and Radiology Assistant website. To give you a brief introduction about CAT scan and what exactly is the physics involved, basically it's a machine which produces X-ray, and the X-ray tube produces a narrow beam of X-rays which is collimated. Collimation means that the beam passes through lead-lined spaces which prevent the beam from scattering around. Now, these X-rays then pass through the patient's body, and depending on the various tissue structures in the patient's body, they are attenuated or stopped or reduced in intensity to different degrees. There would be structures like fat, which would attenuate the beam less, whereas calcium in the bones would attenuate the beam strongly. And then once these different tissues attenuate the X-ray beams to different degrees, the beam is then picked up by a set of detectors, and the detectors then divide the CT slice into squares called voxels, and using a mathematical calculation, the degree to which a tissue absorbs radiation within each voxel is calculated and assigned a value which is called Hounsfield units. And to give you a sense of what the normal structures density measurements in terms of Hounsfield units are, you can look at this chart or so essentially we take water as 0, and then air is taken as minus 1000, and bone is plus 1000, and then obviously there are other tissues like white matter, gray matter. And now a few words about anatomy. This is the orbit, this is the cerebellar hemisphere, the cisterna magna and the medulla, and then frontal lobes, the temporal lobes, cerebellum, pons, frontal horns of the lateral ventricle, frontal lobes of the brain, the temporal lobes, the insular cortex, the sylvian fissure, the occipital cortex, pineal gland. Again, some of the normal anatomy: the thalamus, the frontal horns of the lateral ventricles, the frontal lobes, the temporal lobes, the occipital lobes, the choroid plexus, the pineal gland, the anterior limb of the internal capsule, the posterior limb of the internal capsule, the genu, the caudate head, the lentiform nucleus. Now, please remember this structure, the lentiform nucleus, which I'm going to be talking about a little later in the lecture. And again, the white matter tracts called corona radiata, and then again, this is now you can divide it into the frontal lobe and the parietal lobe, and the central sulcus is the one which divides it into the frontal and the parietal lobe, and this is the fox. Now, typically we use a CT scan for a few indications, although MR has replaced the CAT scan in a number of or rather most of the indications, but CT scan in a trauma setting has a very high value. This is an example of a subdural hematoma or acute subdural hematoma. As you can see, the frontal horn of the lateral ventricle on the right side has been pushed away. The left frontal horn of the lateral ventricle is obliterated. There is this blood which is seen along the convexity of the left side, and there is a lot of edema, and there is a midline shift, or what is known as subvolcine herniation. Um, Here is another example of a chronic subdural hematoma, and when we define it in terms of the chronicity, acute subdural is hyperdense or high density, which is less than 3 days. Subacute is 3 to 21 days, which is the same density as the rest of the brain, and chronic is more than 3 weeks, which is less density. So if you look here, this is a sort of chronic to subacute to chronic um, subdural hematoma, and as you can see that the density measurement is very similar to that of the brain, and there is some midline shift from the left side to the right side. Here again you see this collection, which is a subdural hematoma, which is the chronic subdural hematoma. My next case is an acute epidural hematoma, which is typically because of laceration of the middle meningeal artery in the temporoparietal region, which is the most common presentation. In children, it can be because of laceration of the venous sinuses. This is an example of subarachnoid hemorrhage. Remember, this is blood along the sulci of the brain. Um, Now, this is because of trauma, but bleeding in case of bleeding due to a ruptured aneurysm can also cause subarachnoid hemorrhage. But I will show you an example. So this is an aneurysm that you're seeing, and it has ruptured. And so you see blood mainly in the basal cisterns, although some blood would be seen in the sulci. The difference between a traumatic and a non-traumatic subarachnoid hemorrhage is that typically in case of trauma, you see blood mainly along the sulci, whereas in case of an aneurysm, you see blood along the basal cisterns. So an important thing to remember. I want to introduce another entity called diffuse axonal injury, which is caused by deceleration and rotation of the brain. These are shearing injuries, and the cause, this is the most common cause of post-traumatic vegetative state. In other words, the patient either does not recover after head injury or is in a prolonged vegetative status. MRI is better than CT in terms of diagnosing of the DAI or diffuse axonal injury than CT scan, and it is this entity is typically seen at the junction of the gray matter white matter, also in the basal ganglia and the splenium of the corpus callosum. Now, what is the goal of CAT scan imaging in a patient with acute stroke? I would like to sort of make some facts clear to you. We want to rule out hemorrhage or bleeding within the brain. Once we have ruled out hemorrhage within the brain, the next step is obviously to give the patient thrombolytic agents. Typically, it is preferable that the patient has presented in the emergency room within 4.5 hours, 4.5 hours. And I want to introduce a concept about penumbra. My source of this slide is the radiology assistant. So here we are showing these are the middle cerebral arteries, MCA, and you see that there is occlusion of the left MCA or middle cerebral artery. Now, the black area is the area where there is an acute infarct. So this is all dead tissue, the black tissue. Around that is the area which is called penumbra, which is the tissue at risk. By giving thrombolytic agents, we hope to open up this area or this artery and perhaps save this area, which is the penumbra. If the person comes within the stipulated time of 4.5 hours, we can salvage most of the brain, which is at risk. Now, CT scan is somewhat limited, and diffusion weighted imaging, which is a part of the MRI of the brain, is highly sensitive and specific for diagnosis of an acute infarction. But CT scan does show some findings which go along with a diagnosis of acute infarction. These include hypoattenuation of the brain tissue, there is obscuration of the lentiform nucleus, there is a sign called dense MCA sign, there is also a sign called insular ribbon sign, and then there is loss of sulci or effacement of the sulci. So I'm going to show you some of the examples. Here is an example where you're seeing hypodensity. Now you compare this area with this area. You see the sulci here clearly, whereas you've lost the sulci. And in case of the middle cerebral artery infarction on a CT scan, if you see an area of hypoattenuation which appears within 6 hours, it is highly specific for irreversible ischemic injury. Now, this is another sign that I was talking about. This is what is called the obscuration of the lentiform nucleus or blurred basal ganglia. This is an important sign of infarction. This is seen in middle cerebral artery infarction. It's an earliest and most frequently seen sign, and the basal ganglia are almost always involved in the MCA infarction. Now, the next thing to talk about is the insular ribbon sign. Now, this region is very sensitive to ischemia because it is the farthest removed from collateral flow. So if there is occlusion of the MCA, it is farthest away from the collateral flow, and you see this area of hypodensity, this area of hypodensity, and this area of hypodensity. Now compare it to the other side. Now this is a normal sylvian fissure and insular cortex. See how this is low density compared to this area here. So that is what is called an insular ribbon sign. Um, and the last thing I want to mention is the dense MCA sign. Now here, this is the MC of the right side, which you barely see. Normally you don't see on a non-contrast CT scan. Here you are seeing high density within the left MCA. And if you look at an angiogram, CT angiogram, this is a CT angiogram, and you see how there is a sharp cutoff here compared to this side. So these are the findings that you will see on a CAT scan, and CAT scan is valuable in two situations, definitely in trauma, acute trauma, as well as in acute stroke, to rule out a bleed. Once we have ruled out a bleed, we can go ahead and give the patient thrombolytic agents.